My name is Dr. Ian Storch. I'm a board certified gastroenterologist and osteopathic physician, and you are listening to D.O. or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
On today's episode, we interviewed Dr. Miko Rose, a psychiatrist and the founding dean for the proposed Indiana University of Pennsylvania. The first question is, why is it called Indiana University if it's in Pennsylvania? She'll discuss this as well as the importance of the school and why it is so vital to fill the underserved primary care need and what the school plans to do to accomplish this. She'll also discuss how this is one of the few new osteopathic schools that are state funded. She will discuss growing up in an indigent family and how she discovered medicine and ultimately came to osteopathic medicine after exploring other specialties such as naturopathic medicine. She'll talk about her journey through medical school and how she discovered psychiatry. This is an amazing do not miss episode. Miko, thank you so much for joining us today.
Thank you so much for having me.
So you were recommended by Jordan Keys, who I think is absolutely awesome. So
Agreed. She's amazing.
And the specific reason why she recommended that we speak to you, you are the founding dean of the Indiana University of Pennsylvania, which I don't understand that. So can you tell us a little bit about what that means? And the school's not open yet, but what's going to happen and what the plans are?
So I was very happy in my existing roles. I was working both at Michigan State University at both their College of Human Medicine, their College of Osteopathic Medicine, as well as working at Pacific Northwest University of Health Sciences as an assistant dean of clinical education. And I had this unique opportunity and was recruited to come to IUP, Indiana University of Pennsylvania, and help them lead the charge of creating a brand new osteopathic medical school in a public statewide institution. I had not heard of IUP prior to being recruited. It's the Indiana University of Pennsylvania, the city and town of Indiana, and the University of Pennsylvania PASHE statewide system network schools. Pennsylvania likes to name some of their cities after states. So there's also California, you keep discovering new cities. And so we're actually in the state of Pennsylvania, where a lot and a majority of the communities throughout this state are rural, throughout mountain areas, Appalachia, yeah.
So what made them decide to open an osteopathic school, and how did they get a hold of you?
So they had a phenomenal recruiting group that I found out later when I ended up hiring them for hiring my team. They said, we don't advertise. We tend to look for people that aren't looking, and they tend to be the right people. I hope that I have proven them right in my role, and they certainly have proven the team that I just hired for 2 associate deans right. The origin story on this one was very interesting. So across the nation, undergraduate and even graduate institutions across the nation are having declines in enrollment, and that's been occurring even prior to COVID in 2020. There's this new rebranding of higher education, even though people talk about the meld and the creep, and in certain arenas needing higher levels of degrees in education in order to have access to many jobs and roles. This new generation of learners and our evolution of economy, that frankly likely started with some of the dot-com industry. There have been all these elements and areas of breaking barriers that one doesn't necessarily need the undergraduate and graduate degrees to the same degree that they used to, if you will. And so, like many other institutions, IUP, Indiana University of Pennsylvania, we coin IUP, had seen some challenges in enrollment like other schools across the nation. The local hospital, Indiana Regional Medical Center, also had some interesting conversations around economic development in the town of Indiana, looking at rural medicine and rural health. And the president of the infrastructure of the Indiana Regional Medical Center, which is the local hospital here just 5 minutes away from the university, and Dr. Michael Driscoll, who is the president of IUP, got together and started to discuss what are some things that we can do collaboratively to help solve this problem. Because IRMC and Dr. Wolf were seeing challenges with physician recruitment, retention, healthcare workforce throughout the rural region, which is not uncommon across the United States, and particularly hardest hit are the rural regions. And Dr. Driscoll had seen that there was also equally similar challenges with enrollment overall. And so they together had come up with this. At the time, it was considered just a harebrained, crazy idea of starting a medical school together. And it was such a community-based joint effort that they discussed who should start this medical school. Should it be based at the hospital? You know, as I'm sure you well know, we have some hospital-based medical schools or infrastructure, corporate funding and sponsorships, and hospitals that sponsor medical schools. We also have obvious academic institutions, and they went back and forth and had decided through the academic infrastructure, which already pre-existing, it would be easier to build on that and start the medical school here. So they hired a pre-feasibility study expert group, quite well known in the osteopathic industry for doing pre-feasibility and feasibility studies. One of the founders was from Pittsburgh and knew the regions very well, came in and did a pre-feasibility study. They were beyond thrilled with some of the potential economic impact and results, not only for the potential to help bolster the university and create a new workforce for this local hospital and their neighboring regional healthcare networks, but also looking at the economic development impacts on the community and surrounding neighboring towns. So it's very, very powerful.
Yeah, that's interesting. So along those lines, there are MD schools, obviously, in Pennsylvania. I know in Philadelphia, there's a number of MD medical schools and LECOM, PCOM. So do we need another DO school in Pennsylvania?
When we start to look at the numbers, and I don't know if you've seen any of the predictive data on the US shortage of primary care and physicians, and then you look at rural regions and those projections, and then you look within rural Pennsylvania, there is an estimated shortage, and this is based on 2015 data from 2015, because even though some of the numbers are 2018 and 2020, the actual data was sourced back to 2015. So 10-year-old data before the mass exodus, before COVID, all the different implications. There is projected to be a shortage of 1,032 primary care physicians in Pennsylvania. And that is, we from everything that we can see, quite an underestimate. Then you look at this phenomenon called the rural disadvantage, where in spite of all of our advances in technology and advances in medicine, these curable, treatable diseases called avoidable deaths, right, that I'm sure you've heard about, cancer, diabetes, those number one risk factors and deaths that people have suffered the greatest, highest mortality, is almost, it's getting better and better in urban areas. It's almost close to zero. So the good news is unavoidable deaths in urban areas, they seem to be improving steadily, right? The not so good news is that what we're seeing is that many of those doctors who might have been in rural regions are leaving their practices and clinics, going to the larger hospitals. Students are graduating, going more and more into specialties, right? And we see this trend so that it's now being coined the rural disadvantage, because rural regions are seeing not only an increase in avoidable deaths, but an incredible exodus of healthcare and particularly physicians, but healthcare workers across industry from the rural regions who are leaving to go to more urban or less rural regions. And so that's really, really hurting these rural regions where they are already desperately in need of healthcare. Then when we look at osteopathic versus allopathic medicine, well, why would one choose to be a DO? Beyond all of the pieces, and full disclosure, I am completely biased, and I chose to be a DO rather than pursuing being a naturopath and acupuncturist. I just think holistic medicine and looking at the body as a unit and a whole is absolutely crucial and essential. And I personally chose not to follow a holistic medicine path that didn't take health insurance as traditionally, and chose becoming an osteopath because I thought, I can do all these holistic approaches and I can take health insurance, right? When we look at some of the metadata, and IUP and IRMC really looked at this, they looked at what does it take to start an allopathic medical school? What does it take to start an osteopathic medical school? The infrastructure of what they had pre-existing was stronger towards osteopathic medicine in that creation. Additionally, when we look at, as our profession, our stats and predictability, we tend to go more into primary care, right? So, you say that there's other osteopathic medical schools and other schools traditionally, and I have a close colleague, Jack Brose, who's from Ohio University. He spoke of this, that there was a medical school, it was an allopathic medical school. People were very nervous there'd be some sort of competition. And it turned out that he worked very, very closely with the neighboring medical school because they were an allopathic based institution and they knew they weren't going to have enough primary care clinicians, and that osteopathic medicine is well known to have 57 to 60% of its graduates entering primary care. And so we have that incredible ability as a profession to close that gap in the primary care shortage. And further, underserved rural regions, DOs, we tend to hit a home run on the national stats, regardless of the studies and stat and research that you look at. And so, top 10, we're always very high up there, and often majority of those numbers for rural and underserved. So it was a pretty easy yes for them to look at osteopathic versus allopathic towards what their goals were and the gaps they were trying to solve, to say osteopathic medicine is really the right answer.
Sounds awesome. Yeah, that's
Yeah.
perfect. You know
Yes.
this stuff cold. That's great.
This town, Indiana, Pennsylvania, have you been here? Have
I've
you
never
ever
been
heard?
to, never been.
So I just came out and saw the town, and this is a town that is the Christmas tree capital of the world. They celebrate Christmas kind of throughout the year, but the entire like December becomes and parts of November becomes a Christmas explosion, and there's lights all over the streets and the stores, and it's just where Jimmy Stewart was born and raised. And I really believe when they say in the motto of the town is "It's a wonderful life with kindness and compassion is central," that really is what's here. So it was a very easy yes for me.
Tell us what the plan is. I think I want to go to the school. Tell me when is
I
it
know, right?
open?
You're like, you
Yeah.
can help. We need help.
When is it going to open, and what are the plans for the school?
Yeah, you had mentioned a little bit earlier when we were talking about all the different pieces that it takes to come into play. And I'm sure you well know, coming from an osteopathic institution yourself, that the requirements in national crediting is, while it's down to a science, we cannot predict what the reporting will be. We can only work with consultants and experts within the field and then hire a team that is well versed in COCA requirements. But certainly there are pieces beyond our control, beyond just doing our best to meet the standards. So our plan right now is to open in the fall of 2027. We are in applicant status right now. We'll be going for candidate status shortly, and the pre-accreditation status shortly thereafter, to be able to matriculate students in 2027. We will officially be able to recruit, accept applications, and all of that likely at around May, June, July of 2026. So about just a little bit under a year before.
That's exciting. That's very exciting.
Yes.
Now, one of the issues that always comes up with new schools, and I don't want to speak for all the schools, but I mentor a lot of students, pre-medical students that are applying to osteopathic school. There are a lot of positives to a new school, such as you're kind of involved in the fabric of something new and developing something new. All those things are really exciting. But sometimes one of the hiccups, I think, when students are applying are finances. So obviously, I don't want to say this is all new schools, but some new schools, I know students have issues where it's a little more difficult to get financing over an established school. Do you know about this? Can you talk to us about this in
Yes.
general for DO schools and MD schools, and then specifically how this would affect your school, and maybe if there's a cost benefit to being a state school?
Yes. So, being a state school, we, as an institution and a university, have a history of significant funding through the state. And what's this Pennsylvania statewide system, getting direct allocations directly from the state to help financially support all of the university infrastructure, which is any programming that falls under those universities also get some of those funding, some of those funds. In addition, we have some local government and statewide government who are providing some very generous support towards the creation of the first public osteopathic medical school. So we're getting some funding there as well, of millions of dollars a year to help support the infrastructure to help us build and grow this institution as we start to build really from the ground up. The piece that's not from the ground up is that we are already an institution that has had infrastructure for 150 years. It's actually our anniversary of 150 years at Indiana University, Pennsylvania. And what that means is that we already have full accreditation through Middle State. So rather than creation of a standalone new medical school, we have an opportunity to apply as an additional program under the framework of an existing institution. unlike many of the standalone medical schools, which I know many of the leaders and the colleagues who've had just incredible structures, curricula, innovative learning styles, opportunities to do brand new, exciting things. And like you, I mentor many, many medical students. Although I'm not recruiting for IEP, we are not recruiting, so Coco knows we're following our regulations. I would just say, in general, to our general future budding public population of future medical students, you want to make sure that you're looking at your financial aid opportunities. And yes, for the new schools that are standalone, there are some challenges around financial aid, and that until they've been accredited for a certain number of years, one cannot get, is it I believe it's the public financial aid in some of the loans, and that they can only take out private loans under some of the standalone universities, which for programs that are under infrastructure of an existing university, they already have that financial aid status through an existing university. So we fortunately, through a number of different venues and opportunities, have, if you will, a little bit more structure already embedded into the support of this medical school, because we are not building a building out in sort of the middle of a field with very little support. We have a 150-year history of a statewide institution that has been building and strong for decades.
So, Miko, again, just to build on that question, sometimes, again, I speak to pre-medical students and they have a lot of opportunities, and maybe some of them are equal, and they ask me, and this may not be the best way to approach things, but they say, which school should I go to? And sometimes I'll recommend, like, maybe try to see what the cost is and go to the cheapest school, which, again, maybe that's not the best advice, but sometimes it's an important thing to think about. And sometimes when we talk about osteopathic schools, this is one of the questions, like, osteopathic schools on average are more expensive than the allopathic counterpart, again, for various reasons that we've discussed on the podcast. Do you foresee, and obviously the school's not open yet, but do you foresee that it's going to be on the lower end of the spectrum, or it's going to be in the middle? Do you think it's going to be sort of on the average of what the newer schools are costing?
Because we're so early in our development, I can say that we anticipate being on the lower end. Now, where on the lower end of the spectrum is that? Is it just below the median and slightly lower? Is it way, way, way on the low end to potentially almost free? I have some very clear visions of what I'd like to do on my side in the fundraising. And so that, I would say, a big yes, our plan is to be at least less than the median and the average expense of an osteopathic medical school. And my goal over the next 3 years is to make it dramatically lower, so that we can look at the impact of low tuition on future generations of physicians and that debt burden.
Right. And obviously, when we talk about primary care, a lot of issues are we pushing medical students into higher paying specialties potentially because they need to pay off their loans, right? So,
Exactly. Exactly. My goal in fundraising is to make it dramatically lower than the average, and stay tuned to see how we do.
all right, Miko. So that sounds awesome. I'm excited, but we're going to shift gears now and talk
Yeah.
about you. Can you tell us where you grew up, where you went to college, and when you decided you wanted to go into a career in medicine?
I don't even know about your history. You're asking these questions of a psychiatrist. So I grew up in an unincorporated township. It was called the York Center Township, about 22 miles west of Chicago, in the city line. So interesting, if you traveled into that area now, it's a budding suburb. It didn't look very rural. It didn't look anything like it did when I was a child. At the time that I was there, I lived in an unincorporated township. We lived in what was called a co-op, where they had a lot of sort of non-typical background folks coming together and buying homes, and shared things like wells and different resources. It wasn't like a commune, but it was really truly like a cooperative of shared resources. That was, I believe, started in the 50s, and they were really kind of looking at cross-cultural opportunities for families who didn't have the same types of opportunities to buy housing. And so my parents bought into that housing when I was 5 years old. I consider most of my childhood to really, my formative years, to have been there. I had some friends in school. I was kind of a little bit more of a loner, I guess. When we lived on an acre of land, I would walk just back and between neighbors' deep fields and areas, would just kind of go in the back in the woods and just kind of walked. And some of my closest friends were like geese and animals that I would just see on a regular basis as a kid, just spending a lot of time like out kind of in the woods, just exploring. For me, the concept of becoming a physician was something I had never considered. And as I started to move forward as a child, I grew up in poverty. I grew up with powdered milk, and my dad was an engineer who had a lot of challenges. I did a lot of contract work, but he really kind of was challenged. And financially, we were always trying to make ends meet. I still remember in that first house that I loved so much seeing mushrooms growing from the ceiling because we had so many roof leaks that he was trying to kind of do these Goldberg different contraptions that he'd create with like different pieces of plastic and all kinds of things that eventually we'd see mushrooms a couple of times a year just growing from the ceiling. I found it fascinating. I didn't, because that was all I knew, I didn't really consider that growing up in poverty was anything other than what I had known. I didn't even have that frame of reference until much, much later in my years when I went to college. For me, becoming a physician, that wasn't even on my radar. It was something I'd never considered. One of my first dentist appointments, I was 9 years old and I had 4 cavities because I hadn't been to the dentist before that. I obviously had like the requisite healthcare visits for going to school and things like that, but even the idea of regular healthcare, it just was many steps removed from something that I had really understood. I ended up applying to a college on the East Coast. It was the only college that I had applied to because I saw that they had great financial aid and they were needs blind. And I knew that I just wanted to go to college that was somewhere different than where I grew up and was on as close to a full ride as they gave at the time to Wellesley College out on the East Coast. Didn't know very much about the East Coast. Was very excited to get an excellent education at an incredibly affordable cost and went out to college. And that's kind of where, much like coming full circle here at IUP in Indiana University of Pennsylvania, we have a large number of our students are first generation undergraduate students. I was not a first generation undergrad, but I was a first generation physician. And so for me, when I went to college, I just knew that I wanted to help people. I wanted to help break poverty cycles. I wanted to help families find new lives and find different ways. Somewhere along the way during college, I also discovered life coaching and became fascinated with mindfulness, meditation, life coaching. I had come from a family background, much like many other families in poverty, with a lot of violence in the household. And I kind of went to college feeling like an imposter in my early 20s, like, oh, is anyone going to find, that here I was in Wellesley College where like back in the day, like women wore pearls to class, these kinds of things. I had never seen those types of things in my life. I went to, they had this closet of clothes that were donated and I would go and get some clothes to try to look nice enough to go to class and kind of blend in, wearing all these donated clothes. And so all of these concepts were completely new to me. I got these serendipitous an internship where I volunteered at a battered women's shelter, and I just stayed very, very true to looking at how people could improve their lives and transform, and discovered life coaching. I had a group of friends at a battered women's shelter put together some funds and said, we're going to fund you for this first life coaching class, and I ended up getting a great scholarship and kind of, as I say, the rest was history. Now, I didn't graduate as a pre-med. I had no idea even at the time that I'd be pre-med. I started working for nonprofit groups in the Boston and metro area, as well as going to like Central America and working on biodiversity projects, looking at ironically, looking at economic development and infrastructure bolstering communities that would then in turn help save the rainforest, looking at access corridors for the jaguars and protecting the rainforest through creative economic development models. And it was through all of these experiences that I started to see if I really wanted to make a difference in people's lives, I wasn't going to be able to do it without addressing their physical health. And so I kind of came full circle as I started to see these themes of humanity, that I really wanted to be some sort of a holistic clinician or provider in some way, helping vulnerable and underserved communities who wouldn't have opportunities to have holistic healthcare. And so I looked at becoming an acupuncturist or, a naturopath and all of those professions to serve the communities I wanted to serve. I knew I'd have to do a whole lot of fundraising, which I've gotten very good at. And I realized that I wanted to be a holistic physician who could also take health insurance. And so the more and more I found out about osteopathic medicine, the more and more it was a very easy yes.
Okay, so that's an amazing story. Now, how old are you, if you don't mind me asking, when you applied to osteopathic school, and what did your application process look like, and where did you end up going to school?
Yeah, so going into medicine was really a second career. I decided that I wanted to be a pre-medical student, having taken no pre-medical courses in my undergraduate college. So I started kind of, life coaching. It's we talk about really envision what you want and sort of just start mapping that out. At the time, I was making a moderate, but a pretty modest salary as a development officer and fundraiser for a nonprofit organization. I knew I needed some money to go back to school. I ended up, through a series of serendipities, buying a condo that had tripled in value in the time that I bought it. Right, it was like in this big boon of real estate, and just refinanced the condo, paid for pre-medical courses, and then just kind of went from there. The pre-medical courses, because I had essentially avoided the more rigorous science courses, were it was quite a lot for me to manage. Oh, I'm really dating myself. My first application was to an osteopathic medical school on the East Coast. It was not NICOM, where we had to print all of the application information materials, and so I had hired a typist to help me type everything out, and then we had made a mistake, and it was just it took a couple of rounds for me to get it together and kind of really apply. And so my first round of applying, I was not successful. I had not good MCAT scores. I think I might have even applied, technically thought about applying twice, because the first one we had one copy. The typist, we messed up the application and we kind of missed the deadline, because you could only get an application through the mail and the post. It was like, oh, my application is like, I can't turn this in. So that was one year. I guess technically we never sent it in. And then the following year I applied, and we printed everything out, and I was not successful. And then started to get feedback like, hey, MCAT scores, you can't just take them and just get any score. Like, you have to get good scores. You have to do research. You have to, I ended up talking with pre-medical advisors, which, I just didn't have that kind of exposure in undergraduate in my college. I knew about it, but it was just not something that I could relate to. The pre-medical students that I was alongside were very well versed. It was just nothing I had considered. So I sought out pre-medical advising, and I contacted my college and alma mater, and they explained to me the things that I needed to do and the steps that I needed to put in place, which included things like get some research experience, like start documenting that you're not just focused on humanities oriented work, but that you also can demonstrate clear core competencies in the basic sciences and the biomedical sciences. And so I started looking at volunteer positions. I started volunteering and working with a physician. I ended up moving from the East Coast to the West Coast in California. So I started working with some prominent individuals at UCSF and did research, benchtop research, kind of, did all the things of getting a research base and creating programming, really inspired and based on some of the things I'd done in the nonprofit industry, and translated much of that into medicine. And then had the experience, learned how to study for a test, and took the MCAT. My scores got much better. And actually, my first round, I was waitlisted at Touro University, California, but then I was accepted for the following year. So just took a year and continued research and got in. But I mean, it was a very, very rocky road for me to get into medicine. And I just was very fortunate all along the way to have people that encouraged me right among the moments that I was like, I can't do this. This is crazy. I've already had a whole career. And just really fortunate to kind of at certain times be at the right place in the right time.
Miko, how did you decide on psychiatry? And then tell us a little bit about your application process to that.
That was almost as adventurous as medical school. So I had always envisioned that I'd be a primary care provider. Like, from the time I started applying to medical school, even when I naively didn't even understand that I needed to have certain MCAT scores and all these different aspects of my application, I had always envisioned working in a rural region, just kind of stepping over chickens and walking through farms to treat people and see people in their homes and their communities as a primary care provider. And so I had always believed that I'd be destined into primary care in family medicine or internal medicine, and my medical school trajectory followed that, so that I did primarily family medicine, a couple of extra internal medicine rotations, but really focused on family medicine. I applied to a residency program in Oregon, where they were starting a residency, much like I started school. And I just loved everything about the town and the program. And essentially been told that applying for a family medicine residency slot, like basically it is full. The slots were all pretty much, well, they couldn't say pre-designated. They had more than the number of slots that they had students who had done essentially sub-internships for the entire year before, and that the opportunity for me to be in a family medicine slot was highly, highly, highly unlikely. And they offered me an internal medicine residency slot. They said, I know you haven't probably considered internal med, but it's not that different from family med. And you have a brand new child. My daughter was 15 months old at the time. And they said, we will give you your first year internship year with no call. That's it. I'm sold. So I went into internal medicine. I also met a lot of folks in a psychiatry residency and was so surprised at how much I had in common with the psychiatry residents. I actually, on one of our first days of the orientation for residency, got into a kayak with the internal medicine and family medicine residents, where one of the senior residents was slamming me over the head. I was wearing a helmet, but hitting me with the head, and one of the paddles saying, Dr. Rose, Dr. Rose, Dr. Rose, go faster. And I remember looking over at the kayak of the psychiatry residents, just kind of laughing and looking at the flowers and floating down the river. And I think my first day of residency, looking back, I probably knew on some subconscious level I had metaphorically gotten on the wrong boat. Even in my internal medicine residency clinic, my patients, when I compare the internal medicine residents in their clinics, they'd say, oh, this gentleman had chest pain, I walked him down the ED, but, and they were doing all these incredible medical workups. I would say, well, I asked my patient things like, these groundbreaking things like, how are you today, right? And they'd start sobbing and telling their stories of being locked up since a child with no food or water, just all kinds of incredible traumas. All of the residents attendings were, what are you saying to your patients? And I said, I'm just asking them how they're doing. And so I just sort of found more increasingly so over my internship and residency in internal medicine that I probably was born more naturally to be a psychiatrist. I just had those inherent skills and interests. And then when I did an elective rotation in psychiatry, which because it was a new program, that was our only option for an elective, I absolutely loved it. So I applied for, at the end of my first year in residency and completed that internship, I applied for psychiatry residencies and was very, very fortunate to connect with Michigan State University and Jed Megan, who said, we just have an unexpected opening, where a resident had just left the psychiatry program 2 weeks before I sent in a letter of inquiry to see if they had openings. And from that, the rest is really history. I came here moving from Michigan State.
When I spoke to Jordan Keys, she said that you are a huge advocate for the osteopathic profession. She said you're a huge advocate for physician wellness and medical education. So obviously, psychiatry going along with physician wellness and medical education, like, okay, great, I get that. But people always ask, where's the osteo? I'm a gastroenterologist, so you could ask me the same question. But where's the osteopathic part of psychiatry? Where's the connection? How do you see that together?
First enter the medical field and industry to then discover wellness. Not ironically, in 2010, when I started my psychiatry residency, one of my attendings at Michigan State just turned to me. He was just, the supervisor that was assigned to me. And he said, if you could do anything, what would you do? And this was in 2010 when people were not talking about wellness or physician, like those terms were not even, I have some stories, but that was not a part of our culture or discussions. And he said, well, if you could just do anything, what would you do? Because we were brainstorming a research project. And I turned to him and I just said, I'd create a happiness course for physicians and teach them life coaching and meditation. And flash forward 15 years later, that is what I did. And when I left Michigan State last year, I had taught for the 9th year in its existence what at the time was the only medical student focused 4-credit class on happiness and well-being, where you got credit for doing meditation and mindfulness every day and created a mindfulness log. And you learned all the different life coaching techniques that I had done research on to test the greatest demonstrated efficacy of interventions that we could do to help ourselves as physicians and clinicians. So I did that in 2010, and it really started with a research project and an incredible, I know you mentor a lot of students, an incredible mentor who really made me believe that the sky's the limit. And it turns out 15 years later, he was right. Interestingly, a couple years into my research, I can't tell you in 2012 and 2013 how many physicians said when they saw my posters at ACOM and OMA, oh, that's a great project, Dr. Rose, but that doesn't really apply to us. Why don't you take this work? You should bring this to nurses or social work, but we don't really see the relevance of this work. Flash forward 4 or 5 years after that, physician wellness, burnout, all the different events that happened in sequential. We couldn't have predicted that. And, fortunately now, the course that I taught and has been continued by other teachers in many various forms, you could throw a stone and find a wellness-oriented course for credit and now required at just about any medical school. So I'm very much a champion of that. I think this piece on how do we keep things osteopathic is not just hands-on, although I do think that having our hands on and touching our patients is very important to show compassion and care and just being present. An osteopathic approach to humans and each other is to look at the full system. Like, what is going on? When I look at a patient osteopathically who has a psychiatric presentation, I look at every different aspect of their lives and every element of their physiology and potential conditions, down from the genetics and predisposed history to each presenting complaint that they have, to see how these tie together, to see where those common themes could be in case these are underlying medical conditions. I can't tell you as a psychiatrist how many times I diagnosed undiagnosed medical conditions, right? Not to like criticize internal med. I was headed in that direction, right? Because they just don't have the time. But for us to send it back and work with the primaries and say, hey, what about this? What have we ruled out? And that piece ends up being so crucial, not just for discovering the key core lesion that's causing a psychiatric presentation of symptoms, but to really helping the patient see themselves as complete and whole and as a system. The beauty of this piece is I'm even looking at starting this as I'm creating the foundation for this medical school. It's an osteopathic approach. We have communities, hospitals, and clinics that are coming to us saying, Dr. Rose, we love what you're doing and creating. We want this to be a community-based medical school. It's so community-based that the community hospital was thinking of starting the medical school instead of the academic institution. And so for me, even an osteopathic approach to administration, when we look at D.O Is and who we are, and I know Jordan said you're very much into this as well. It's like, how do the cells relate to the tissues, and how do the tissues relate to the organs, and each of the organs' relationships to each other to be a whole, and how does each individual patient relate to others in their system, right? Because a psychiatric approach and an osteopathic psychiatric approach is, how do those humans interact with each other as a system, and how do those families and collections of humans and tribes and families, if you will, however they orient, become parts of communities, and how do those communities relate to their systems and their organizations and the state and the infrastructure, and then it becomes this large healthcare system that is living and breathing, and in some cases sick or on life support. We see that as well. And how do we help find the key lesions on those systems with an osteopathic approach to address that and find what are those key lesions within our entire osteopathic profession, to then moving backwards start to retrofit what we can create to solve this challenge of rural health. I think there's ways that we can look at this on all levels. I think there's endless ways. We have in psychiatry, I think I have my copy right, a 500-page book on all the things that can go wrong with the diagnosis in psychiatry. I think as a profession, we need 1,000 pages on all the things that can go right and how we can build successes from there. We don't have that just yet, but it is a body of work that I've been working on since 2010, when a mentor turned to me and said, what would you like? And that body of work is building.
Awesome. And physician wellness, no doubt. We use it kind of flippantly sometimes, but I think as doctors, we definitely can use your help.
Yeah, yes. And that body of work that has fortunately expanded so far beyond anything that I had done, right? It's that ripple effect of individuals and champions who are passionately committed. It's hilarious. People don't even always believe me when I say, no, I can't tell you how many doctors said that it wasn't needed, because it's so well infused into the infrastructure of our culture now. But back in 2010, it wasn't a part of our conversations.
Miko, you're awesome. Thank you for spending time with us today. I have one last grand finale question. Can you give us one piece of advice that you were given from someone else that you feel has been impactful in your career and you would like to share with our listeners?
I have a lot of them. I will say that my number one is having notes to my future self of who I want to be in a moment, 10 years from now, 20 years from now. And it allows me to have a broader perspective. So if I'm frustrated with an encounter with a patient and I'm not able to help them to the degree that I had hoped, it's like, who do I want to look back and see that I was? And the piece that has really struck me time again is people say, who is that person that you want to be? And are you acting as that person now, even if you're not feeling like you're that person in the moment? And that has just served me time and time again. And for me, the added lens is, I want to be someone who my daughter can be proud of. I have one daughter, it's my only child. She's 17. She's kind of the light of my life. And actually, this was advice from a mentor. They said, if you were going to write your own eulogy, what would you want people to say? And so for me, it's been that I was kind and I had integrity. Even when no one was looking and no one cared, did I do the right thing? And that's been very powerful advice. What do you want to be known for, and who do you want to be when you're looking back in your life, and structure the rest of your days from there? And I've really done that, and I would say a lot of people gave me that advice.
I have chills. That's amazing advice. Mika, thank you so much again for spending time with us. I really appreciate it.
Thank you. Thank you so much.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there is someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.